Hello, my name is Paweł Kozłowski. I'm a senior assistant of laboratory medicine at the University Clinical Center of Medical University in Warsaw. I would like to present a case of a teenager with psychiatric symptoms with autoimmune background. Our case is a history of a 16-year-old boy who was diagnosed with mild intellectual disability in the early childhood, but according to his parents, the boy was developing very well. At the age of 16, the boy was brought to GP's office due to sudden change in his behavior. The boy became emotionally unstable. One day he was completely withdrawn and unresponsive, and the other day hyperactive, aggressive, anxious. He was also revealing delusional thoughts, false beliefs. His speech was incoherent. The GP performed an initial examination and found no evident reasons that could explain these symptoms. The basic lab tests were also within reference range, and urine for drugs was negative. Because the GP could not find any reasonable explanation of the observed symptoms, he referred the boy to a neurologist. The neurologist ordered a broad panel of tests in cerebrospinal fluid and in serum to look for any infection and autoantibodies typical for autoimmune encephalitis. He also ordered brain MRI to look for tumor, injury, or signs of stroke. I eyeballled the test that I and my colleague we performed in our department. One test especially drew our attention. That was the test for antibodies against NMDA receptor. At that time, we were using transfected cells to perform this test. Anti-NMDA receptor antibodies should give fine fluorescence pattern of the cell's cytoplasm. In this boy's case, we did not see the typical fluorescence pattern in the cell's cytoplasm. That is why our result for NMDA receptor antibodies was negative. What we saw instead was actually speckled fluorescence of cells nuclei, which looked like typical ANA pattern. Since this specific test cannot be used to detect ANA, we decided to perform ANA test in the cerebrospinal fluid and in the serum. We used HEP2 cells for ANA detection in both cerebrospinal fluid and serum. On your left, you see the picture of HEP2 cells incubated with non-diluted boy's CSF sample. On your right, you see HEP2 cells incubated with diluted serum sample. As you can see, both of these tests show very clear speckled pattern, which means that in both CSF and serum ANA are present. The measured ANA titer was obviously higher in the serum. We estimated it for 1 to 3,200 than in CSF, which was estimated for 1 to 32. We also performed blotting tests to establish the antigenic specificity of detected ANA, and both in serum and in the CSF, the antibodies were specific for U1 RNP complex. These are the antibodies usually described in patients with mixed connective tissue disease, but the boy actually did not fulfill criteria for this disease, though it could not be diagnosed. High titer of ANA in serum and lower titer in CSF means that these antibodies were synthesized outside central nervous system and they were crossing the blood-brain barrier, thus probably affecting the brain and causing sudden change in the boy's behavior. The neurologist was first considering whether the boy can be diagnosed with neuropsychiatric lupus, but actually he did not fulfill American College of Rheumatology criteria for lupus from 2019. Finally, he was diagnosed with undifferentiated connective tissue disease with psychiatric presentation. This is a condition also called pre-lupus, incomplete lupus, or probable lupus, in which there are specific ANA present, but the patient presents single symptoms, for example, psychiatric symptoms like in this case. Patients diagnosed with preclinical autoimmunity have high risk of developing lupus with full spectrum of symptoms. This case is an example of how important the differential diagnosis is when diagnosing patients with psychiatric symptoms. It is known that both mental illness and autoimmunity affecting nervous system can cause symptoms like psychosis, depression, delusion, or anxiety. What differs them is treatment, and only the proper treatment can give good results. Our contribution in this case was a proper assessment of fluorescence pattern we saw on transfected cells. What could be described as interference without clinical importance, we took into account seriously. We did some additional testing that was not ordered by physicians. And thanks to that, we discovered autoimmune process, which was probable explanation of the boy's sudden illness.